about the ATLS chapter 4, that is thoracic trauma. Okay. So in thoracic trauma, the hypoxia is most serious consequences of chest injury. Okay. Most life-threatening thoracic injury can be treated with airway control or decompression of the chest with needle, finger or tube. Okay. So this hypoxia point, the most serious consequences of chest injury, can come in a MCQ. Okay. So if there is a partial airway obstruction, patient may present with stridor. So you have to see upper airway obstruction, stridor. Okay. Now see the tracheobronchial tree injury. Okay. So it's a fatal condition. Majority of the tracheobronchial tree injury occurs within 1 inch of the carina. This is MCQ as previously asked. So most of the tracheobronchial tree injury occur within 1 inch, that is 2.54 centimeter of the carina. Okay. And the mechanism generally rapid deceleration following blunt trauma. Okay. So if there is a tracheobronchial injury, intubation can potentially cause worsen an injury to tracheal or proximal bronchi. Okay. So continued air leak after placement of a chest tube suggests tracheobronchial injury. This can be asked. So if you place a chest tube and there is a large air leak, okay, so it's suggesting tracheobronchial injury. Okay, and so in this case placement of one more chest tube may be necessary. Okay. And bronchoscopy confirm the diagnosis. Okay. And immediate treatment may require placement of definitive airway. Okay. Okay. So fiber optically assisted endotracheal tube placement is immediate definitive airway management. Okay. So it's a fiber optically assisted endotracheal tube placement. Okay. Immediate operative intervention is indicated. Okay. If patient is stable, then operative treatment of tracheobronchial injury may be delayed until acute inflammation and edema is resolved. Okay. Okay. Cyanosis is late sign of hypoxia. This is famous MCQ. Okay. So its absence, that cyanosis absence does not necessarily indicate adequate tissue oxygenation. Okay. So now see the tension pneumothorax. So tension pneumothorax develop when one-way valve or air leak occur from the lungs or through the chest. Okay. And the type of seen in tension pneumothorax is obstructive type. This we have already discussed. Okay. So this picture explains mechanism of tension pneumothorax. So this is one-way valve. You can see the lungs has been shrink and then the pressure has been developed, that collapsed lung. This is collapsed lung. Okay. And this vena cava is also compressed and restricted the filling of the heart. Okay. Okay. And you can see the mediastinal shift towards the normal side. Okay. So marked decrease in venous return causing reduction in cardiac output. Okay. Okay. So most common cause of tension pneumothorax is if the patient is on ICU, so mechanical positive pressure ventilation with visceral pleural injury. Okay. Okay. This can also be seen in blunt chest trauma patient when parenchymal lung injury fails to seal that injury, okay, or after subclavian or internal jugular venous catheter insertion, okay. So in this case occlusive dressing are secure from the foresight. If there is a chest wall injury and you do occlusive dressing from the foresight, it will create a tension pneumothorax, okay. And it is also seen in displaced thoracic spine fracture, okay. So clinical diagnosis reflecting the air under diaphragm, okay, in affected pleural space. So do not delay the treatment to obtain radiological confirmation, okay. So it's a clinical diagnosis. Tension pneumothorax is a clinical diagnosis, okay. So patient will present a tachypnea and air hunger, and in mechanically ventilated patient will be hemodynamically collapse, okay. These are the symptom of tension pneumothorax: chest pain, air hunger, tachypnea, respiratory distress, tachycardia, hypotension, and tracheal deviation away from the site of injury. Already explained, okay. Unilateral absence of breath sound, elevated hemithorax without respiratory movement, neck when distended, and cyanosis, that is late manifestation, okay. Okay. This tension pneumothorax can be diagnosed using extended fast, okay, E-fast, okay, and managed initially with inserting a large bore needle catheter, okay, in pleural space, okay. If there is a needle decompression may not be successful, in this case you can do finger thoracostomy, okay. And that large bore needle catheter placed at fifth interspace slightly anterior to mid axillary line, okay. Important, this asked 100 times in NEET PG exam, okay. So tube thoracostomy is mandatory after needle or finger decompression. So that tube thoracostomy or needle thoracostomy is a temporary measure, so you have to put a chest tube, okay. So now comes see the open pneumothorax. If there is a large injury to the chest wall that remains open, so it can cause open pneumothorax, also known as sucking chest wound, okay. So sucking chest wound or open pneumothorax, okay. So air tends to follow the path of least resistance. So suppose if there is opening in the chest wall is approximately 2/3 diameter of the trachea, so this 2/3 word is important, 2/3 the diameter of trachea, okay, T, okay. So T is 2/3, okay. Or greater air passage preferentially through the chest wall defect rather than trachea, okay. So there is a one typical feature, noisy movement of air through the chest wall injury, okay. Okay. So in this case you have to put the occlusive dressing, that what we were discussing in the tension pneumothorax, and you have to put the plastic wrap or petroleum gauze, and it should be 3 side to provide the flutter valve effect. Do not close from all the 4 sides, okay. It should be always from the 3 side, and it will cause flutter valve effect, okay. Very important line, 3 sides, okay. So place a chest tube remote from the wound as soon as possible. So where you have applied the occlusive dressing, okay, so you don't have to put the chest tube from that wound, you have to put chest tube from remote from that wound, okay, and definitive surgical closure of that wound, okay. Okay. Now come the massive hemothorax. So accumulation of the more than 1.5 liter or 1500 ml of blood in one side of the chest. Important definition, that 1.5 liter of the blood, okay. So this picture has come many times recently in AIMS also, this picture, same picture has come. So dressing of the treatment of open pneumothorax, you can see the 3 sides, wounds is been closed from the 3 side and one side is left open, okay. Okay, so this will cause flutter valve effect, okay. Okay. Now come, now you see pulseless electrical activity. Okay. So this will show the pulseless. So pulse will be absent and electrical activity means ECG. So ECG show no rhythm and there is no identifiable pulse. So this is seen mainly in cardiac tamponade, tension pneumothorax and profound hypovolemia. But this is also seen in hypovolemia, hypoxia, hydrogen acidosis, hypokalemia, hyperkalemia, hypoglycemia, hypothermia, toxins, cardiac tamponade, tension pneumothorax and thrombosis, coronary and pulmonary thrombosis. Okay. So important is it is seen in hypo and hyperkalemia both. Okay. Okay. So let's see massive hemothorax. The same definition with one more line: accumulation of more than 1500 ml of blood or one third or more the patient blood volume in the chest cavity. So one third. Okay, one third. Okay. So most commonly seen in penetrating wound. Okay. Okay. So the patient will present with neck vein will be flagged if there is severe hypovolemia or distended if associated with tension pneumothorax. So in massive hemothorax, neck veins may be flat also if there is severe hypovolemia and distended in case of tension pneumothorax. Okay. So shock is associated with absence of breath sound or dullness or to percussion. Okay. Okay. So the initial management will be restoring of blood volume and decompression of the chest cavity. Okay. And if there is a massive blood is coming from the chest tube, you can do auto transfusion, but you have a suitable device for that. And chest tube size, you have to put a single chest tube only. Okay. 28 to 32 French. Okay. Okay. And if there is immediate return of 1.5 liter or more than 1500 ml of blood, so this is the indication for urgent thoracotomy. Okay, if the surgeon, specialist surgeon is there. Okay. 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 And then if there is a blood loss more than 200 ml per hour for 2 to 4 hours, this is also an indication for an open thoracotomy, and persistent need of blood transfusion is also indication for thoracotomy. So there are three main indication for thoracotomy. If the instant blood coming more than 1500 ml in a chest tube, or continuous blood loss more than 200 ml per hour for more than 2 hours. Okay, 2 to 4 hours, and persistent need for blood transfusion. These three are indication for thoracotomy. Okay. So color of blood is a poor indication for necessary thoracotomy. So this can put a fourth option. So remember, this is poor indication, color of blood. Okay. So penetrating anterior chest wound, or that is medial to nipple line, or posterior wound medial to scapula, that is called mediastinal box. If injury located in this area, possible need of thoracotomy is there. So do not perform thoracotomy unless a surgeon qualified by training and experience is present. Important line. Okay. So there is a one comparison between tension pneumothorax and massive hemothorax. Okay. Okay. So breath sound absent or decreased, both in not that important. Okay. So percussion, there is a tension pneumothorax means air. So percussion will be hyper resonant. In massive hemothorax, blood is present. So percussion it will be dull. Important difference. Then tracheal position. In tension pneumothorax it will be away, and in massive hemothorax it will be in midline. Okay. M for M. Neck veins distended in tension pneumothorax and collapse in massive hemothorax. Okay. And chest movement In tension pneumothorax, expanded, immobile. In massive hemothorax, it will be mobile. Okay. So this picture is showing massive hemothorax. You can see the blood. Okay. And you can see the trachea is in midline. Okay. Now let's see the cardiac tamponade. Important, very important topic. So compression of the heart by the fluid in the pericardial sac, known as cardiac tamponade. So it will cause decrease in cardiac output. Okay. So mostly seen with penetrating injury. Okay. So there is a classical clinical triad known as Beck triad. Okay. So in which you will get muffled heart sound, hypotension and distended neck veins. Okay. So muffled heart sound, since heart is not able to pump, so heart sound is muffled, and if there is no blood is moving, then patient will have hypotension and there is neck vein distended. Okay. And also you will see Kussmaul sign. Okay. So Kussmaul sign. So rise in venous pressure with inspiration when. So Kussmaul sign is rise in venous pressure with inspiration. Okay. So tension pneumothorax. So you may get confused between tension pneumothorax because most of the clinically it mimics with cardiac tamponade, but there is a difference. We discussed in last topic also. Okay. So in tension pneumothorax, on percussion it will be hyperresonance. Okay. Since this is a chest respiratory problem, and there is a bilateral breath sound indicate cardiac tamponade. Okay. So this is the key difference. Okay. So this can be identified in FAST. Okay. FAST can identify the cardiac tamponade. Okay. So this is the picture showing cardiac tamponade. Okay. You can see the blood in pericardial sac. Okay. So if there is a FAST is unavailable or equivocal, you can also do echocardiography or pericardial window. Okay. So if there is a qualified surgeon present, you can do emergency thoracotomy or sternotomy. Okay. If surgical intervention is not possible, then pericardiocentesis can be therapeutic but does not constitute definitive treatment for cardiac tamponade. Important update. Okay. So pericardiocentesis is just therapeutic if surgical intervention is not possible, and it's not a definitive treatment for cardiac tamponade. So how you are going to do pericardiocentesis? It's a subxiphoid pericardiocentesis by Seldinger technique, and we will use flexible catheter. Okay. And complications are in this technique, complications are common. So pericardiocentesis is a life-saving measure of last resort in setting where no qualified surgeon is available. Okay. And if you do ultrasound guided, so accurate insertion of large catheter is possible. Okay. So try to do, if you are doing, try to do ultrasound guided. Okay. So now there is one more, traumatic circulatory arrest. So if the patient is unconscious and no pulse, this you can comes under traumatic circulatory arrest. Okay. So patient will have ventricular fibrillation or asystole. That is the true cardiac arrest. Okay. So circulatory arrest is diagnosed according to clinical finding. Okay. So patient is, the key clinical findings are unconscious and no pulse. Okay. And in this condition you can start giving CPR. Okay. Cardiopulmonary resuscitation, that is closed CPR. Okay. And you give mechanical ventilation with 100% oxygen. Okay. And you can also do bilateral finger or tube thoracostomy, and if you are performing this thoracostomy, okay, no need to put local since patient is unconscious. Okay. So here is a flow chart how you are going to proceed with traumatic circulatory arrest with no pulse. So you give CPR, okay, less than in 2 minutes, 100% oxygen. Okay, so okay. If there is no ROSC, ROSC is return of spontaneous circulation. So you can do bilateral chest decompression. So it's a bilateral. Okay, just remember it's a bilateral. Okay, and again if there is no ROCS, no spontaneous respiration, you can do anterolateral, or means you have to do thoracotomy. Okay, okay, okay. So if there is a cardiac arrest, okay, so you have to do internal cardiac massage. Okay, if there is cardiac arrest, you have to do internal cardiac massage. Okay, or internal electric shock, and you have to declare death after 30 minutes of resuscitation. That 30 minutes is important, and temperature is more than 33 degrees Celsius. Okay, okay. There is one point I want to explain. If you have done thoracostomy and patient is having severe hypovolemia, so you can do in abdomen you can clamp the descending aorta. In thorax you have to put hemostasis clamp or loop. Okay, okay. Now comes to the secondary survey. So 8 potential lethal injury that can be managed during secondary survey. So that is simple pneumothorax. Remember, this is we are doing in secondary survey. Okay, secondary survey. So simple pneumothorax, hemothorax, flail chest is important. You may get confused. So flail chest, pulmonary contusion, blunt cardiac injury, traumatic aortic disruption, traumatic diaphragmatic injury, and blunt esophageal rupture. Okay. So in simple pneumothorax, the lung laceration with air leakage. So most common cause of pneumothorax from the blunt trauma. So in if there is a patient is having blunt trauma, so lung laceration with air leakage is most common cause of simple pneumothorax. Okay, okay. You can see the air trap, and this is collapsed lung. Okay, okay. So upright expiratory chest X-ray you have to take. So there is 2 word important. So upright and expiratory. Okay. Okay. So any pneumothorax is best treated with chest tube. Okay, and chest tube placed in 5th intercostal space, anterior to mid axillary line. Remember. So 2 anterior cannot come, anterior to anterior axillary line, no, anterior to mid axillary line. Okay, okay. Now comes to hemothorax. Okay, so hemothorax is blood less than 1.5 liter accumulated in pleural cavity. Okay, if more than, it will come and massive hemothorax. So it is less than 1.5 liter. Okay, and it's because of laceration of lung, great vessels, intercostal vessel, or internal mammary artery. Okay, okay. So bleeding is usually self-limited and not required any operative intervention. Okay, and on percussion you will see the dullness. Okay, and chest X-ray with supine position you take. Okay, and you will see the homogeneous opacity. So supine position, important is supine position. Okay. So acute hemothorax, that is large enough, that appears on chest X-ray treated with chest tube. Okay. So if on chest X-ray you diagnose hemothorax, you have to put a chest tube. It is as simple as that. Okay. So again this line, this is important, that's why they are repeating again and again. If greater than 1.5 liter of blood obtained immediately on the putting a chest tube, more than 200 ml per hour of 2 to 4 hour, and if blood transfusion is required. Okay, so consider operative exploration. Okay. So now come flail chest or pulmonary contusion. So what is flail chest? A segment of chest wall does not have any bony continuity. Okay, so it is two or more adjacent rib fracture in two or more places. So keyword are two, okay, adjacent rib or two places. Okay, and it is also occur when there is a costochondral separation of single rib. So single rib also can cause flail chest when it is separated from costochondral junction. Okay. And pulmonary contusion can occur without rib fracture also. Okay, it can be one liner. So most common potential lethal chest injury. Okay, that pulmonary contusion. So this is picture of flail chest. So flail chest is very important for any entrance. Okay, so chest x-ray may suggest multiple rib fracture but not so any costochondral separation. Okay, so initial treatment of flail chest is and pulmonary contusion is humidified oxygen, adequate ventilation, and the cautious use of fluid resuscitation. Okay, because it will cause volume overload and compromise respiration. Okay. So patient with significant hypoxia, that is partial pressure of oxygen is less than 60 or 8.6 kilopascal or saturation is less than 90 on room air, may require intubation or ventilation within first hour. Okay. So definitive treatment of flail chest and pulmonary contusion. Okay. So you have to manage the analgesia, okay, through IV narcotics, okay, and intermittent intercostal nerve block. Okay. So now comes to the blunt cardiac injury. So it is mainly seen in motor vehicle crash, or if the person is fall from great height, that is more than 20 greater height more than 20 feet or 6 meter. Okay. So true diagnosis of blunt myocardial injury can be established only by direct inspection of injury of myocardium. Okay. So on 2D echo you will see valve motion abnormality. Okay. If the patient present with unexplained sinus tachycardia, atrial fibrillation, or right bundle branch block. Okay. And if you do blood investigation, you will see cardiac troponin also raised. Okay. So patient without ECG abnormality do not require any further monitoring. Okay. Now see traumatic aortic disruption. So it's a common cause of sudden death after vehicle collision or fall from great height. This is asked many times. Sudden death after vehicular collision. So sudden death is the keyword. Okay. So two important: vehicle collision or fall from great height. Okay. So possibility of surviving tends to have when incomplete laceration near the ligamentum arteriosum. Okay. It's usually fatal. Okay. Patient die mostly on the spot only. So this picture is aortic rupture. Okay. So history of deaccelerating forces will be there. Okay. So radiographic sign of blunt aortic injury asked many times. So you will see the widened mediastinum. Okay. Obliteration of the aortic knob, deviation of trachea to the right. Okay. Then depression of the left main stem bronchus. So there is a deviation of the trachea to the right. Okay. But depression of the left main bronchus. Okay. And the elevation of the right main bronchus. Okay. So elevation of right side, depression on the left side. Okay. Then obscuration of aortopulmonary window. Okay. Then deviation of esophagus towards the right side, or you will see the nasogastric tube is shifted to right, and widened paratracheal stripe. Okay, or widened paraspinal interface, okay, and presence of pleural or apical cap, and left hemothorax will be there, and fracture of the first or second rib or scapula. So important, first, second and scapula. Okay. So in investigation, helical contrast enhanced CT scan is accurate screening method patient with suspected blunt aortic injury. So important word is helical and contrast enhanced CT. Okay. So used for screening. Okay. If the result are equivocal, you can go for aortography. Okay. And transesophageal echocardiography is also useful. So heart rate and blood pressure control can decrease likelihood of rupture. Okay. So you have to remember the few data. So short acting beta blocker to goal of heart rate should be less than 80 beats per minute and mean arterial pressure less than 60 to 70. So 60, 70, 80. So 60 to 70 should be mean arterial pressure and 80 is less than 80 is pulse rate. Okay. And you can also use beta blocker, calcium channel blocker, nitroglycerin, nitroprusside. Okay. So endovascular repair is most common option. Okay. If there is a low resource facility, you are working at low resource facility, you should refer the patient on higher center without delay. Okay. Then traumatic diaphragmatic injury. So it is more common on the left side because of on the right side lever protect the diaphragm or obliterate the defect. Okay. So blunt trauma produce large radial tear and penetrating trauma produce small perforation and patient will be mostly asymptomatic for years. Okay. So elevated right diaphragm is only finding on the right sided injury. Okay. So left diaphragm injury you will see when gastric tube can be inserted and gastric tube appears in the thoracic cavity. Important line. Okay. So if it cannot be identified on initial X-ray, you can go for CT scan or contrast study. So peritoneal lavage fluid in the chest tube drainage also confirms the diagnosis. Okay. So this is the diaphragmatic rupture. Okay, you can see this is the diaphragmatic rupture. Okay, here also this is diaphragmatic rupture. Abdominal content in the thorax. Okay, so treatment is direct repair. Okay, now come to blunt esophageal rupture. So esophageal trauma most commonly by penetrating injury. Okay. So patient will have left pneumothorax or hemothorax without a rib fracture. Okay. So in a question they will give left pneumothorax or hemothorax without rib fracture. So you understand they are talking about esophageal trauma. Okay. So you will presence of mediastinal air should be there and it is confirmed by contrast study or esophagoscopy. Okay. So treatment of esophageal rupture is wide drainage of the pleural space and mediastinum with direct repair of injury. Okay. Now subcutaneous emphysema. It is do not require any treatment. If patient is require positive pressure ventilation, so consider tube thoracostomy on the side of subcutaneous emphysema. Not that important. We are about to finish one more page. So rib, most commonly injured component in thoracic case. This is one liner. Okay. So upper rib 1 to 3. So fracture of scapula first and second rib or sternum. It is suggesting the patient is having associated serious injury. Okay. Now middle rib 4 to 9. Okay. So most of the effect of blunt trauma. Okay. So there is a mid shaft fracture of the rib. Okay. So middle rib is 4 to 9. Okay. And most of the time this middle ribs affect. Okay. So multiple rib fracture in young male imply the greater transfer of force than older patient because they are flexible. Okay. So osteopenia is common in older, so delayed development of clinical hemothorax. Okay. So now come to the lower rib, that is 10 to 12. So in this, if there is you found the lower rib fracture, so there is a chance of on the right side liver injury, on the left side splenic injury. Okay. Okay. The last line, if there is a rib fracture, tapping, rib belt and external splint are contraindicated. Okay, remember that. Okay, and you can do intercostal block, epidural anesthesia and systemic analgesic are effective. Okay, so don't apply rib belt, external splint or tapping. Okay, in rib fracture patient. So thank you.